And this clarifies the rule of keratocytes in these situations. Now we come to the sensory innervation of the cornea. It's the most densely innervated tissue. It's even more densely innervated compared to skin. So it has around 2,500 nerve terminal per millimeter square. This is a very big number. It's supplied by cranial nerve 5, the trigeminal nerve, specifically the ophthalmic division, more specifically the long posterior ciliary nerves. They are 2 in number, and they enter the eye in the horizontal meridian. They are in the exact horizontal meridian. So this is the optic nerve entering the eyeball from behind, and 2 to 3 millimeters from the dural sheath covering, there is what we call the wreath of the short posterior ciliary arteries. They are multiple, might be 15 to 20, and just on the horizontal meridian, nasally and temporally, there are the 2 long posterior ciliary arteries, just few millimeters outer to this wreath, entering the eyeball through what's called the scleral canal. They run in the choroid anteriorly until before the ora serrata. The ciliary nerves ramify and supply the conjunctiva, sclera, and cornea. So this is a trigeminal ganglion, and it's giving the ophthalmic. The ophthalmic is giving the nasociliary nerve, and the nasociliary is giving the 2 long posterior ciliary nerves. Long ciliary nerve conveys sympathetic supply besides the sensory supply, while short ciliary nerves supply sensory, sympathetic, and parasympathetic. You need to revisit the questions on nerve supply of the eye, on the ciliary ganglion, tragopalatine ganglion. These are very important questions. At this stage, we have reached the ramification of the long posterior ciliary nerves. So, at the limbus, it forms like a plexus, nerve plexus. It gives few branches to the sclera and conjunctiva, and gives other branches going into the cornea to supply the cornea. We can move now to this picture. So from the perilimbal neural plexus, nerve fibers pass into the anterior 1/3 of the stroma, ramify there, and then branch and penetrate in between the basal layers, forming free nerve endings within the epithelial cells. These free nerve endings does not contain specialized receptors like passinic corpuscles, for example. they are sensitive for any stimulus except temperature. So the cornea usually is not sensitive to cold except from the tissue changes in response to temperature. Cornea is very hardly sensitive to hot sensation, to warmth, but it might feel some cold, and this happens within the exposed free nerve endings. What do I mean by exposed? What I mean is these stromal nerves, or the nerve ramifying in the stroma, they lose the myelin sheath around 1 to 2 millimeters from the limbus, but they retain the Schwann cells. So you find like a nerve running like that, covered by Schwann cells here and there, and the nerve can feel or respond to stimuli through irritation or stimulation of these exposed areas. These areas might feel cold, and by the way, this subtle cold sensation is not anesthetized by topical anesthetics. So you can add this to the bupivacaine. You remember the MCQ question on bupivacaine, the only topical anesthetic anesthetizing the proprioceptors in the iris is bupivacaine. This is important for topical anesthesia, cataract surgery, of course. So you can assess corneal sensitivity by either qualitative or quantitative methods. So qualitative, this is something objective. It depends on the patient. So you usually divide the cornea into 5 areas: central area, superior, nasal, temporal, and inferior quadrants. And then with a cotton tip, you test sensation if the patient feels the sensation in each quadrant or not, added by plus or minus, and then compare it to the other eye as well. This is something qualitative. Might be not that accurate, but the quantitative method subjectively is using this device. This is called an aesthesiometer. So this aesthesiometer has a nylon filament within, and you can push it forward, and by measuring the length of the nylon filament, that initiated stimulation or that initiated sensation in the cornea of this patient. So this is subjective assessment. Then we move to causes of corneal hyposthesia. Herpetic eye disease is the commonest cause, either herpes simplex and more commonly herpes zoster virus infection. Surgical or iatrogenic, like cases after LASIK, PRK, I would add the cases undergoing PRP, 360-degree laser, barrage. As we just mentioned, these are the causes of corneal hyposthesia: herpetic eye disease, most commonly herpes zoster; surgical iatrogenic like LASIK, PRK, PRP 360-degree laser, cryo, CPC. by the way of collateral damage. By the way, collateral damage happens most commonly with diode laser, which is commonly employed nowadays in these laser procedures. And intracranial masses, acoustic neuroma, chemical injury, topical anesthetics, and topical NSAIDs, chronic use. Neurotrophic keratopathy.